Studies show that both approaches can lead to great results, and your long-term success depends more on your strength, mobility, and consistency with rehab than on one single surgical choice. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Welcome back to the Total Knee Success Podcast. I'm Michelle, and today we're unpacking one of the questions I hear often, and that's, did they replace my kneecap, or is it still mine? It's a great question because it gets right to the heart of what makes a total knee replacement so unique. During surgery, most of the work happens on the joint surfaces. That's where your femur, the thigh bone, meets your tibia, the shin bone. Those surfaces are reshaped and fitted with implants that act like smooth, durable gliding partners. But the patella or kneecap, which is also one of the surfaces, is generally handled differently, and that's what we're going to talk about today. By the end of this episode, you'll understand exactly what might have happened to your kneecap, how resurfacing works, what different implant designs use for patellar component, and how you can find out what your surgeon chose for you by reading your surgical report or asking at your follow-up visit. There are two main options when it comes to the patella: leaving it as is or resurfacing it. If the cartilage on the back of the patella looks healthy and smooth, the surgeon may leave it alone, perhaps just trimming rough spots. But if the cartilage is worn, uneven, or softened from arthritis, the surgeon may choose to resurface it. That means carefully removing a few millimeters from the underside of the kneecap and bonding a small, smooth polyethylene button to that surface. It's important to understand this. The kneecap itself is not removed and replaced entirely in conventional knee replacements. Your bone, your tendons, and your muscle attachments, they stay intact. The button goes underneath, facing the femur, not on top where you can feel it. It simply replaces the damaged joint surface so the patella can move smoothly within its groove. It's common practice for surgeons to reach the back of the patella by gently lifting and rotating it outward during the operation. The tendon stays connected and the bone is preserved. It's an incredibly precise step that allows for a new surface without disturbing the stability of the surrounding tissues. Surgeons generally have a philosophy about resurfacing, and that's shaped by the implant design and the surgeon's experience. In general, if the cartilage is healthy, it can often be left unresurfaced. If the cartilage is worn or irregular, it's often resurfaced. And if you have a thin or fragile patella, it can often be left alone to avoid fracture. This is decided on an individual basis, and you'll often have a discussion with your surgeon about it. So ask a few questions about this on your pre-op visit, or ask some questions on your first or subsequent post-op visit so you can really understand what's happened. Some implant brands are designed specifically to pair with a resurfaced patella, while others are optimized to move smoothly against your natural bone. Either way, the goal is a knee that bends, tracks, and feels natural. Large studies, including one by Chen et al. In 2013, Fu et al. In 2018, and a 2021 Cochrane review, show no significant long-term difference in pain or satisfaction between resurfaced and non-resurfaced knees. Resurfacing may reduce the chance of needing a future surgery for persistent kneecap pain, while leaving the patella natural slightly reduces the risk of patellar complications like fracture or loosening. So, in the big picture, both approaches can work beautifully when chosen for the right reasons. While we're talking about surgical details, let's touch on another common question. What happens to the ligaments inside the knee during total knee replacement? In most modern total knee replacements, the anterior cruciate ligament, or ACL, is removed because it attaches to an area of bone that's replaced by the metal components. Depending on the type of implant, the posterior cruciate ligament, or PCL, may either be preserved in a cruciate retaining or replaced with a built-in mechanical substitution in a posterior stabilized design. The collateral ligaments on the inside and outside of your knee, the MCL and LCL, are always preserved because they provide side-to-side stability and are essential for walking and balance. And I mean that in a standard knee replacement. If you have some sort of reconstructive design, the surgical procedures may vary. Your surgical report will often list these details, terms like PCL retaining or posterior stabilized, or ultracongruent describe exactly how your implant handles those ligament functions. Regardless of resurfacing, how well your patella moves, called patellar tracking, has a huge impact on how easily your knee bends. We talked about this a couple of episodes ago when we talked about range of motion. If the kneecap doesn't glide freely, flexion can feel stiff or restricted. A 2012 study by he and colleagues found that people with good patellar mobility after knee replacement had significantly better bending and less pain. That's why physical therapists often spend time on gentle patellar glides and soft tissue work, no matter what kind of patellar surface you have. So while your implant design matters, the freedom of movement in your kneecap plays an even bigger role in how the knee feels day to day. Many patients don't realize they can find out exactly what was done to their kneecap and ligaments by reading their surgical report. It's a great document to have. You can request a copy from your surgeon's office or hospital records department. Look for terms like patellar resurfacing performed or patella retained. Look for terms like posterior stabilized or cruciate retaining or ultracongruent. These describe the implant's design. If you're unsure, just ask your surgeon directly. Did you resurface the patella or leave it as is? I'm sure they'll be happy to explain. And it's one of the best ways to understand how your new joint was built. Recent studies, including those published as recently as 2022, continue to show that resurfacing and non-resurfacing both deliver excellent outcomes at 10 to 15 years post-op. A registry-based analysis by Sturmer et al. In 2019 found similar patient-reported satisfaction and pain scores, but resurfacing slightly reduced the number of reoperations for anterior knee pain. Another 2020 follow-up by Fu and colleagues confirmed that the difference in long-term function was negligible, reinforcing that either option can succeed when surgical alignment and soft tissue balance are optimized. In other words, the skill of your surgical team and the quality of your rehab matter far more than whether your patella was resurfaced or not. Be sure to consider red flags if you notice new grinding, catching, or a sharp pain directly behind the kneecap, or if your range of motion suddenly decreases significantly, contact your care team. Persistent warmth, redness, or swelling around the patella should also be checked promptly. These signs don't always mean something serious, but early evaluation can prevent complications and help keep you on track. Remember, your kneecap is still your own bone, even if it's been resurfaced. The small plastic button sits on the underside of the bone, where it meets the femur, not on top. It replaces the damaged surface without removing your patella or its tendons. Your surgeon's decision to resurface or not is based on your anatomy, the implant system, and the condition of your cartilage. Studies show that both approaches can lead to great results, and your long-term success depends more on your strength, mobility, and consistency with rehab than on one single surgical choice. If you're curious which approach you had, ask your surgeon and review your surgical report. It's your knee, and knowing what's inside helps you take better care of it. Next time, in episode 16, we'll turn to scar healing, how to help your incision heal optimally as it matures and move comfortably as your knee keeps improving. This podcast is for educational purposes only. Discover more at totalkneesuccess.com, and be sure to subscribe and share, because every step forward takes you closer to living the life you love.